inicio a este webinar con el tema que nos ocupa de alta relevancia, de resiliencia en los sistemas y servicios de salud. Creo que todos sabemos que estamos en este momento viviendo unos momentos de transición, prácticamente esperamos, de transición de la pandemia COVID con todos los desarrollos, incluso el aumento cada vez mayor de cobertura con la vacunación, una transición que esperamos concluya en un periodo post-pandemia y para la cual el tema de la resiliencia de los sistemas y servicios de salud, no solamente para poner fin a esta pandemia, sino para lograr recuperar las pérdidas en las metas de salud pública y recuperar también el camino hacia los objetivos de desarrollo sostenibles y la salud universal es un tema fundamental. Con este objetivo, la OPS, junto con la OECD y el Banco Mundial, han decidido realizar este seminario y tenemos el honor de tener 3 panelistas destacados, 2 de ellas, de los panelistas mujeres, lo cual creo que tenemos un buen balance de género en el webinar. Así que contaremos con la presencia de Francesca Colombo, que es dirige la División de Salud de la OECD, con Zara Shubber, que es la team leader en el Banco Mundial en el bloque de resiliencia de sistemas de salud, y por supuesto el doctor James Fitzgerald, que es el director del Departamento de Sistemas y Servicios de Salud de la OPS, una servidora como moderadora. Mi nombre es Amalia del Riego y soy la jefa de la Unidad de Servicios y Acceso en el Departamento de Sistemas y Servicios de Salud. Y sin más preámbulo, bueno, les indico que este webinar tendrá traducción simultánea a inglés y español, así que pueden elegir su canal de preferencia. Y yo en este momento voy a proceder sin más preámbulo a hacer la introducción de la primera presentadora y en esto voy a hacer una pequeña cambio a inglés. La doctora, la colega Francesca Colombo, es como mencioné, is the head of the Health Division at the Organization for Economic Cooperation and Development. She oversees the OECD work on health, which aims at providing internationally comparable data on health systems and applying economic analysis to health policies, advising policymakers, stakeholders, and citizens on how to respond to demands for more and better healthcare and make health systems more people-centered. Major activities of the OECD Health Division covers the response to the COVID crisis and solutions to make health systems more resilient, trends in health spending, measuring of healthcare outcomes, activities and inputs, healthcare quality policies, assessing health systems efficiency and value for money, health workforce, long-term care systems and aging, the economics of public health, pharmaceutical policies, new technologies, big data, and artificial intelligence in health. Mrs. Colombo has over 20 years of experience leading international activities on health and health systems. Over her career, she traveled extensively in Europe, South America, and Asia, advising governments on health systems, policies, and reforms. And I invite Francesca Colombo to initiate with the first presentation. Francesca, adelante.
Sure, thank you very much. And I will be speaking in English, my Spanish and Portuguese being quite rusty, having lived many years now also in France. But I want first of all to thank James and PAHO for organizing this very timely webinar and the World Bank for participating. I think all of our organizations, all of societies and governments are really very much reflecting on this idea of how to make health systems more resilient. And the crisis has caught many of us by surprise, by the magnitude and the scale at which it has developed. and clearly had not just significant implications in terms of human suffering, people quality of life, and the health impacts, but it has also lasting consequences in terms of the economic impacts and the impact on social systems. So quite clearly, we cannot afford moving forward to have health systems which are not resilient enough to a crisis. And this notion goes a little bit beyond the pure pandemic preparedness itself, because it has to do also with the ability really to recover and adapt from health systems. So with that, I would like to just share a few slides to accompany my talk. And we are having at OECD a lot of reflections on these notions of resilience. And these reflections actually benefit from initial work that was done in the context of another crisis, the economic and financial crisis that happened over 20 years and over 10 years ago. And there was a realization that you need to put in place something to avoid health system from having catastrophic disruptions. And that as part of that, you need to be able not just to plan for major disruptions that might happen, but also absorb a shock when it comes and recover and adapt. So the notion of resilience that we use at OECD, which is actually adapted from the Army Corps of Engineers in the United States, consider those various elements. It acknowledged that there is a possibility that there are massive disruptions that can happen in health systems, and that actually systems, health system, but also interconnected systems, need to be prepared for that and need to have the capacity and the planning for recovery and for adaptation from those major shocks. It also takes into consideration the fact that when we talk about resilience, we're not talking in a narrow sense about the health service delivery only, but we really need to take a view of interconnected systems. So consider, for example, the health and the elderly care system, consider the supply chains of health goods and services, consider the innovation model as well, and that all those elements are very much interconnected. And when something goes wrong, there can be cascading errors that multiply across the system. And this involves really looking not just how to prepare and to absorb a risk, but also the ability of the system to recover and adapt. And I will make some reflections on that. This is very much work in progress that we are doing. So in no way I have the solutions for making health systems resilient, but there are already a number of elements that come to the fore. So the first thing, obviously, it's the issues of preparedness. And preparedness is key because the cost, obviously, of investing upstream, it's indefinitely low if we consider the cost.
Invertir. Al considerar el costo de la pandemia,
the cost of preparing for disruptions really is minimal compared to the cost of the disruption itself. And countries really need to make sure that they understand these issues and that they're ready to ensure that the system is strong enough against those disruptions. But the very first element of it is really to make populations themselves more resilient. So it's not just the resilience of health systems themselves, the services which are provided, how they are financed and so forth, but the populations themselves. And this chart shows an illustration of how much is spent on preventative care as a share of total health expenditure for a number of OECD countries. So OECD goes beyond Latin America, it includes Europe, it includes the Asia Pacific. But consistently, we see a very low level of investment in preventative care. We're talking about the order of 3% of total health spending. And quite clearly, those who have suffered the most from the pandemic are those who are more frail, those with multiple chronic conditions, those living in poverty, those also who are more susceptible to being infected because of the informality of the labor market and combining elements of poverty. So the clear first issues is the investment in prevention, which is fundamental one, and in which, despite having mentioned also these low investments of 3% for many, many years, even OECD, we still don't see any significant change happening in countries. A second element of preparedness, which I want to draw your attention to, has to do with the data and the data system. I mean, quite clearly, we live in an economy which is digitalizing increasing speed, and all the sectors of the economy are reaping also the benefits of that digitalization, but health still remains very much behind that process of digitalizations. An example is shown in these slides, which shows the number of countries that were able to produce timely and report timely data in the context of a crisis. And we see that very, very small number of countries are able actually to generate and create data which are recorded and included in national data sets to support both planning as well as clinical assessment and improvements, and also research. So it's of the number of countries that responded to a survey that we have done. Only about a third were able to do that for primary care and prescription medicines, but really very low numbers for some other of the critical data that we need in the health system. And that has to do very often with a poor data infrastructure and governance of health system, too often concerns about privacy, which impedes having data governance that allow data to flow across different parts of the system and to be used and shared, obviously, in a privacy respectful way. I wanted to mention also the issues of supply chains and the importance of strong supply chains, which is both an element of preparedness, but also of absorbing when a crisis happens. And we have clearly seen the vulnerability of global supply chains in the context of the pandemic for different types of products, personal protective equipment, medicines, the ability of, also procure tests, but also the reagents which are used for the tests. And the graph that is shown on the right is an illustrative example. It's actually from a class of antibiotics. Antibiotics are not used for viral infections, but a lot of the people who had COVID-19 also had other types of health needs requiring antibiotics. And more generally, the point to illustrate is really the vulnerability of supply chains. So what this shows that for this one class of antibiotic, the B-lactam antibiotic, if you go from the right to the left, you see a progressive reduction in the number of actors, in the number of companies which are present and active at different level of that supply chain. So if you go into the final product, the marketing and sales, you have about 40 companies. If you go up to the drug productions, you have about 10 companies which do, also the finishing and dosage from the manufacturing. Further upstreams, you have only 2 manufacturing of the critical ingredients that goes into the antibiotics, and you have only 1 intermediate supplier of raw material. So what we see here is that the lack of diversification of supply chains for, in this case, a class of antibiotics, does create an element of vulnerabilities in the context of a major shock of the crisis. And I think we need to shed much better light on these elements of vulnerability, understanding much better what is the structure and exposure of the risk of the global supply chains, identify also possible approaches and policies to address it, and improving the preparedness for the future. And that's a critical element, obviously, of preparedness. There are elements of preparedness, obviously, which relate very directly to the pandemic elements. I will not spend much time to that, but obviously the possibility of having systems which are set up for effective testing, the vaccination, for infection control, also for alert system, disease detection, even sequencing capacity for a new pathogen. All of these are critical importance, but will not spend much time because there is a huge discussion already on those purely preparedness related elements. But if we go downstream, then we need to think, okay, once we are ready, once we are prepared, a disruption can happen. And at that context, what is fundamental is the ability to absorb that disruptions, maintaining the continuity of care, having a very strong front line of health services. And here, just a couple of illustrations again, the critical factor that we have seen happen in countries, which is limiting really the ability to respond to a shock and to provide care both to people directly affected by COVID-19 in these cases, and those indirectly affected is the ability of enough trained health professionals. And what we find is that in not all countries, that is very much reliant on having GPs, primary care doctors, which are able to uphold care for all. But despite the fact that we know the critical importance of primary health care, in countries over the years, we see a reduction in the share of generalists, which is available even in the most advanced economies. And this is something which is a trend that we find really consistent in all countries. So not only we're facing with a global level, a shortage of health professionals, which is actually something in the order of 18 million of healthcare workers missing in a way, a shortage, particularly in low and middle income countries. But in addition, we keep on providing more specialized expertise and training specialists, forgetting that the fundamental parts of the health system is really what the GPs can provide. Another element of the absorb is the ability to, in a context of a crisis, to be very agile, very, very quick, to mobilize resources, to mobilize services in a way which is not rigid. And unfortunately, health systems are still very much rigid. If you consider even the health workforce, we have doctors and nurses and other health professionals, each with very, very specific roles, which are set almost in stone, very difficult to have advanced nurses role, for example, or different type of activities that professional can do. But there are other parts of the system which are rigid. Before the pandemic, for example, there was hardly any telemedicine. And here, and it shows in this graph how much this has been actually, in a sense, freed up. We see a significant share of people who had medical consultation online or by phone in the context of the pandemic in some countries, and these are European countries, but if you look on the left, you see Spain, Slovenia, and Poland. We're talking about nearly 60% or above of the people who had the medical consultation online. So in a context of crisis, some of the in a sense, rigidities, some of the blockage linked to lack of reimbursement mechanism, linked to institutional weaknesses and institutional rigidities were unlocked. And that opens possibility, obviously, for the future for much more agile delivery of services. But another element of agility is really perhaps the need for health systems to look beyond the health sector itself and learn how other sectors have done it. So, for example, there is lots of discussion in the financial sectors, again, originated by the then economic financial crisis, about how to avoid cascading failures. There could be learning there to bring into the health sector, but also the ability to avoid shocks that we can learn from other sectors like electricity sectors, where there are some capacity mechanisms which are put in place by regulators to ensure that there is a minimum critical quality and quantity of services which needs to be made available at all times, irrespective whether it's a normal time or a time of crisis. And what the regulator does is that they go out for auctions for providers who are able to meet those quantity guarantees. So I think there is probably a need to look at what other sectors have done, precisely to avoid breakdown in times of crisis. Now we're trying to do a ROIC, it's initial calculations of what would it mean in terms of costing all of that, because quite likely there would be a need to invest more in health systems. Certainly some health systems already have enough resources, but others don't. But if we look together at those foundational elements of preventions, investing in information systems, of strengthening the supply chains, if we look at more the containment aspects, which have to do with infection control and more the issues of having enough tests and vaccine, which are typical to the pandemic. And if you look at the need for manage and uphold care for all, particularly the health workforce being the most critical component, we see that there are needs for spending more on health in OECD countries in the order of about 1.5% of GDP more, of which 2/3, I should say, actually come from the needs to invest more in health workforce. So there are definitely questions that come up, and let me just conclude with some considerations also on the importance for health system to recover and adapt when you have, a shock of this sort. And again, the consideration for that health system needs to operate not just in normal time, but also how they function and continue to function when they're under extreme pressure, so as to avoid breakdown. And that implies thinking of resilience, not just in terms of interventions which are done exposed once you have a shock, but also resilience by designing the system in order to be able to uphold critical functions, even in times of disruptions. There are also other considerations that these might require, for example, thinking not just in terms of maximal efficiency design, but also in terms of resilience. So the example of the electricity sector, which I mentioned, takes into consideration the need to have some sort of slack capacity or ability to quickly mobilize surge capacity in times of disruptions. But there is probably a need to reflect also on how to incentivize desired outcomes in times of crisis. How do we pay for global public goods such as vaccines or even antimicrobials? Like what should be the type of incentives for the innovation ecosystems? How do we ensure that we have a system that can very quickly speed up critical R&D products? We have seen it in the case of vaccine, but that could apply also to other products. And also it needs to be done in a way that does not disrupt also the R&D for all other critical products. How do we sustain also innovations such as telemedicine beyond the critical moments in which there's been a disruption, so that we learn and make the system improve for the future? And also, how do we make sure that the systems stop working in silos but work much better together? So the health and the long-term care system, the health and the economic system, the ecosystem of innovation and support. This will raise obviously critical issues about also how do we pay for these investments, how do we ensure sustainable financing, critical ensuring continual value for money that remain key. Agile financing mechanisms are essential in times of crisis, but there is probably also a need to consider how to balance financing for preparedness with agility as well to response in time of crisis. So lots of questions which still remain there. As I mentioned, we are looking at many of these issues. This is just a little bit of a publicity of a website where you find a number of analyses that we have done, but we will continue at the OECD to explore the issues of resilience of health systems. The hope is obviously that we'll be much better prepared for the future, and that we take a broader approach, which, as I mentioned, moves beyond just pure pandemic preparedness, but embrace a system approach to preparation. Thank you very much.
Thank you, Francesca. Muchísimas gracias. So I will now introduce. Voy a decir que al final de las presentaciones vamos a tener, por supuesto, un espacio para preguntas, comentarios y discusión. Así que les pido que los que quieran vayan anotando sus preguntas si quieren en el chat o en la sección que dice preguntas y respuestas, Q&A, y continuamos con nuestra próxima panelista. So Dr. Zara Shubber is a senior health specialist and the team lead for health systems resilience at the World Bank. Zara has more than a decade experience working in a variety of healthcare contexts, from developed to low-income countries and those characterized by fragility, conflict, and violence across Europe, Africa, Middle East, and Asia. Before joining the World Bank, Zara worked as a consultant for a number of international organizations, including the World Health Organization, the Bill and Melinda Gates Foundation, and Medicines Sans Frontières, as well as in an academic setting at Imperial College London's Department of Infectious Disease Epidemiology. Zara is a physician and infectious disease epidemiologist by background and has published 35 peer-reviewed journal articles in the field of health. I would like to welcome Zara, Dr. Zara Shubber, for the next presentation. Zara, adelante.
Great. Thanks very much, Dr. Amalia. And thanks to PAHO for organizing the event. And just thank you very much for the opportunity to join the panel today on a topic that is extremely timely. It is a real pleasure to join the OECD and Francesca and PAHO on this important discussion. I don't have slides, but I will provide a perspective on health systems resilience. So the COVID-19 pandemic, like previous health emergencies, really put a spotlight on the fragility of health systems worldwide. Francesca showed some data, but as we saw, even in the most developed countries, their systems were overwhelmed with surges in demand. And we saw shortages of hospital beds, diagnostic tests, and personal protective equipment. The pandemic also disrupted essential health services, especially in low and middle income countries. So the World Bank's Global Financing Facility for Women, Children, and Adolescents conducted an analysis of more than 60,000 health facilities across 10 countries. And they found substantial disruptions in child immunizations, antenatal and postnatal care, and safe deliveries by skilled health workers as a result of the pandemic. But it wasn't just the poorest countries where we saw significant disruptions to essential health services. In the United Kingdom, for example, almost 1 million British women missed a breast cancer screening appointment during the height of the first wave of the pandemic, and there were 30% fewer diagnoses of breast cancer. So today we really have an opportunity to learn from the pandemic and capitalize on the global momentum to transform health systems. And neither health security nor universal health coverage can be achieved without building resilient health systems. So how do we view health system resilience and how do we achieve it? I think the first point that I want to highlight is that at the bank, we are really thinking about the intersection between emergency preparedness and resilience. Our team has conducted a literature review of more than 1,000 papers on resilience and the capacities and capabilities of resilient health systems. Such capacities include having leadership and command structures, having flexible plans and management structures, timely and flexible access to crisis financing, and so on. What we also found is that a lot of the focus of resilience has been on the response aspects, which makes sense given that much of the historical focus of resilience has come from the disaster risk management field. However, one of the key lessons from COVID is that we need to focus on prevention, we need to strengthen preparedness, and therefore we need to focus on the actions that we need to take in the inter-crisis periods. So how do we strengthen preparedness? First, of course, we need predictable and sustainable financing. International financing is, of course, important, but it is best suited to capital and one-off investments, such as labs or equipment. And all our preparedness experiences shows that the most important expenses are recurrent. So maintaining functioning facilities and sufficient skilled health workers. And these recurrent expenses are best addressed through national health systems financing. So it really needs to start at the country level. We need to build country capacity for efficient and effective prevention and detection of outbreaks, as well as the capacity to contain and mitigate them. So not allowing small flames to become raging wildfires, as we saw happen with COVID in many parts of the world. So we need to invest in public health. But what we have learned from previous crises is that vertical approaches are not the answer. We need to make sure that investments in preparedness in public health are integrated into the health system, into the UHC agenda. And given the context of the fiscal crisis, as well as the slow burning or chronic stresses we are seeing in the health system today, due to growing aging populations, growing burden of NCDs, and so on, integration is going to be more critical than ever. So we need to maximize our investments so that they also benefit the health system day to day. So at the World Bank, one priority that we see, Francesca also talked about it, is really leveraging primary healthcare for preparedness and response. And we see resilience as one of the key paradigm shifts that is needed in primary healthcare, that is moving from fragility to resilience. This includes, for example, the use of primary healthcare teams to conduct public health surveillance, the inclusion of public health into training for primary healthcare workers, and building in surge capacity into health sector planning and resource allocation. which brings me into my next point, which is linked to how we should address surge capacity. If we build a health system that can address all demands in times of crises, we would have a lot of excess capacity in times of non-crisis. So it may not be optimal to have a lot of surge capacity residing in the public sector, or at least everywhere. What we have seen from COVID is that not all places are hit equally bad at the same time. So an important part of surge capacity is how you allocate that capacity. For example, transferring medical equipment, teams, and even patients from overwhelmed areas to less embattled ones. For example, when Po Valley in Italy or New York in the United States were overrun, there was spare capacity nearby that could have been utilized. Another key strategy that countries have used is to tap into other sources of capacity, for human resources especially. So as an example, I stopped working as a doctor in the UK a decade ago. And when COVID hit, the General Medical Council reached out to people like me, as well as medical students and retirees, to come back to the health system. There have also been many countries where the private sector has played a very important role in surge capacity, for example, to scale up testing. And we've also seen many innovative solutions from the private sector, for example, on the repurposing of fleets for cold chain transport. So really is an opportunity to leverage the private sector for surge capacity. In terms of improving the performance and quality of health systems, including in the inter-crisis periods, service delivery reorganization and innovation is going to be critical. So for example, pregnant women should be able to deliver their babies in facilities that have the right equipment, competent staff, and with access to emergency care should they or their baby need it. Primary healthcare should also be strengthened to provide continuous coordinated care, which is especially important for chronic conditions. And again, Francesca showed some nice data on the sort of unprecedented rise of telemedicine solutions in health service delivery. And really, this is an extremely important point. Really, COVID has advanced decades of telemedicine policy in just a year. And this is one shift in service delivery that will very likely stay with us post-COVID-19 and should be capitalized on. The next point that I would like to highlight is the importance of population health and household and community resilience. COVID-19 has shown us once again that vulnerability to a pandemic or to any health emergency is not uniform across society. So for example, those who are obese or live with non-communicable diseases are much more likely to have severe COVID-19. And we are going to see more and more the rise of syndemics. Air pollution is becoming an increasing threat in many parts of the world, which is why we have made green recovery a key priority for the bank. I earlier referred to the data from the GFF on disruptions to essential health services, for which the data also showed that demand side barriers play an important role. So for example, financial barriers where people no longer had money for transport to facilities due to the economic downturn. And we've also seen many countries with relatively good public health systems become overwhelmed with surges in cases because households were not able to adhere to public health measures due to, for example, the need to work, having informal work, and living in multi-generational households. So we need to take a wider multi-sectoral approach, and why the World Bank has committed a record $160 billion to the wider COVID response to protect the poor and vulnerable who inevitably suffer the most from any crisis. Preparedness really requires also investing in social protection systems in schools. We are particularly concerned about the impact of COVID on human capital formation. Our key immediate priorities to contain the pandemic and ensure equitable access to vaccines. But in addition to our health work, our education teams have been totally focused on building resilient education systems, and our social protection teams focused on mitigating the impact of the pandemic on livelihoods and jobs. So I will end by emphasizing that the World Bank is fully committed to this important agenda and to working with our partners and countries to strengthen emergency preparedness and health system resilience. Thanks very much, and I look forward to the discussion.
Gracias, Sara, por excelente presentación. Y ahora vamos a pasar a la presentación del doctor James Fitzgerald. James Fitzgerald is the Director of Health Systems and Services at the Pan American Health Organization. I have the privilege to work with James in his team. He oversees the PAHO WHO work program in health policy and governance, health systems and services organization, health workforce, financing in health, health research and access to medicines and health technologies in the region of the Americas. As Director of Health Systems and Services, he has led the development of reference policy frameworks to guide health sector reform to achieve universal health based on the primary healthcare strategy in the Americas. He has coordinated the strategies to strengthen health systems resilience, health services organization, workforce capacity, and regulatory systems development, development of medicines and medical products. He oversees the management of the PAHO Strategic Fund, a pool procurement mechanism in the Americas to improve access to public health supplies, as well as the PAHO Virtual Campus, a capacity building platform with outreach to more than 1 million health workers in the Americas. It's my great pleasure to introduce Dr. James Fitzgerald for the next presentation. James, adelante, por favor.
Muchas gracias, Amalia. Buenos días a todos. Voy a hacer mi intervención en español, ¿no? Es un gusto estar aquí hoy con ustedes. Un gran saludo a Francesca y Zara, y muchas gracias por sus intervenciones. Esta discusión para nosotros es muy oportuna también porque la próxima semana tenemos en los cuerpos directivos de la OPS una discusión con los países, estados miembros de la OPS sobre el tema de la resiliencia en los sistemas de salud. El 13 de junio, ahí la región reportó 70 millones de casos de COVID-19 con más de 1.8 millones de fallecidos en todos los 56 países y territorios. La pandemia realmente ha impactado toda la región con una crisis general, social, económica, que realmente ha aumentado los niveles de empobrecimiento en toda la región. Estoy intentando cambiar a slides. ¿Ustedes, Amalia, está viendo la presentación?
Sí, pero no ha cambiado el slide.
No ha cambiado, entonces voy a ver cómo. Así es, ok. Bueno, entonces el camino hacia la cooperación requiere la intensificación de las acciones para el control de la pandemia, pero no solamente esto, el despliegue rápido de la vacuna COVID-19 y la mitigación de interrupciones en la provisión y disponibilidad de los servicios esenciales de salud. Una transición progresiva de la respuesta a la pandemia hacia la recuperación necesita un enfoque renovado en la construcción de sistemas de salud resilientes en todas las Américas. Aquí en 2016 los países de OPS, de Estados miembros, definieron la resiliencia como un atributo fundamental de los sistemas de salud bien desarrollados y que funcionen bien mediante el cual los actores de la salud, las instituciones y las poblaciones se preparan para afrontar crisis y responder eficazmente a ellas, manteniendo las funciones básicas cuando surgen crisis y reorganizarse en función de las enseñanzas extraídas si las condiciones los exigen. El acceso a continuidad de servicios de salud para programas de salud ha sido altamente impactado en la región, como los programas de salud mental, salud materno-infantil, enfermedades crónicas, transmisibles, inmunizaciones, sobre todo en países de menor ingreso. A partir de marzo de este año, la región de las Américas ha registrado la mayor tasa de mortalidad excesiva de todas las regiones de la OMS, incluso debido al impacto indirecto de la pandemia, siendo el exceso de mortalidad mayor en los quintiles de menores ingresos. Los resultados de las encuestas que hemos realizado en 24 países entre octubre de 2020 y febrero de 2021 indican que el acceso a los servicios de salud para el diagnóstico y tratamiento de diabetes, de enfermedades cardiovasculares y cáncer realmente ha empeorado. La situación de los servicios de salud mental es aún peor, con incrementos en la demanda de estos servicios y una reducción en la disponibilidad de los mismos. Para responder a la pandemia, los países están concentrando sus esfuerzos en salvar vidas, realmente asignando los recursos necesarios para el control de la pandemia a nivel hospitalario, inclusive reasignando los recursos humanos de salud a otros niveles del sistema hacia el nivel hospitalario. Al mismo tiempo, las medidas de salud pública y la alta tasa de infección de recursos humanos han producido disrupciones graves en la prestación de los servicios de salud en el primer nivel de atención. La pandemia también llega a una región marcada por una matriz de desigualdad social, cuyo ejes estructurantes, el estatus socioeconómico, género, la etapa del ciclo de vida, la condición étnico-racial y el estatus migratorio, entre otros, generan escenarios de exclusión y discriminación múltiple y simultánea que redundan en mayor vulnerabilidad ante la enfermedad. Estas desigualdades también se expresan en el ámbito de la salud, tanto en cobertura como acceso efectivo y los resultados de servicios de salud, como en las condiciones basales de salud de las personas y las comunidades. Además de las inequidades preexistentes en materia de salud, la pandemia encuentra a los sistemas de salud de los países de la región como importantes debilidades. Se trata de sistemas de salud subfinanciados, segmentados y fragmentados. Las debilidades en el ejercicio de la función de la rectoría, de las autoridades de salud y en las funciones esenciales de salud son acompañados por aumentos demasiado lentos en el gasto público. Se mantiene lejos de la meta de 6% del PIB recomendado por la Organización Panamericana de Salud y alcanza un promedio de 3.7% del PIB, considerando el aporte fiscal y el de la Seguridad Social de la Salud. El alto gasto bolsillo también redunda en una desprotección financiera que empobrece a los hogares que deben recurrir a altos pagos directos cuando acceden al sistema de atención. Cerca de 95 millones de personas realizan gastos catastróficos en salud en la región y casi 12 millones de personas se empobrecen debido a estos gastos. A partir de enero de este año, muchos países de la región alcanzaron un punto de quiebre en la tasa de ocupación hospitalaria, por encima del umbral de la tasa de ocupación del 80%, especialmente en las unidades de cuidados intensivos. Durante de los UCIs, se usa cada vez más difícil mantener y ampliar aún más la capacidad de ellos. Se enfrentan a agotamiento de personal de salud y a retos para asegurar los suministros y medicamentos de emergencia para el manejo de casos de COVID-19. Por ejemplo, oxígeno, analgésicos, medicamentos para intubación, anticoagulantes, etc. Entonces, considerando lo anterior, ¿qué queremos para los sistemas de salud para el futuro? El camino hacia la recuperación post-pandemia y el logro de los objetivos de desarrollo sostenible es mediante la construcción de sistemas de salud resilientes en las Américas. Los sistemas de salud deberían facilitar y acelerar primero la recuperación de los logros perdidos de salud pública, abordando las inequidades y el impacto de la pandemia, la expansión del acceso de cobertura en salud con enfoque de equidad y mejorar la preparación y la respuesta ante futuras emergencias de múltiples riesgos, en particular las pandemias. Consideramos que necesitamos acción en 4 áreas, con liderazgo, rectoría, inversión y gobernanza efectiva del sistema de salud, con una visión hacia la transformación del sistema de salud, hacia el logro de la salud universal. Como mencionaron por Zara y Francesca, la primera línea que estamos proponiendo a los países Estados miembros es la transformación basada en la atención primaria de salud hacia la salud universal. La APS es una estrategia que aborda las necesidades de las personas, las familias, sus comunidades, a través de una atención integrada y de calidad, incluida la promoción de la salud y la prevención de enfermedades. Proporciona una plataforma para la rápida recuperación de los logros perdidos con enfoque de equidad, al tiempo que constituye una inversión en la salud futura de las personas y de las comunidades donde viven. En abril de 2019, la directora de la OPS, doctora Carissa Etienne, lanzó el Pacto para Atención Primaria de Salud 30-30-30, instando a los Estados miembros a transformar los sistemas de salud basados en APS para el 2030, eliminando barreras de acceso a los servicios de salud en 30%, aumentando el financiamiento público al menos del 6% del PIB y asignando al menos 30% de esto al primer nivel de atención. En el contexto en que nos encontramos, realmente es urgente renovar el compromiso ante este pacto. La segunda línea de acción es fortalecer la capacidad de salud pública tras la función esencial de salud pública. Mejorar la capacidad de salud pública implica diseñar y fortalecer estructuras institucionales que pueden coordinar diferentes intervenciones y programas de salud pública con el sistema de salud y entre sectores. Lo que necesitamos es una colaboración y coordinación intersectorial bajo la administración y liderazgo de las autoridades sanitarias para fortalecer esta función esencial de salud pública. En diciembre del año pasado, OPS lanzó la función esencial de salud pública en las Américas, una renovación para el siglo XXI, el marco conceptual y descripción. Y las áreas clave que destacamos aquí realmente es reforzar la evaluación del estado de la población, conocer la población, incluidos los aspectos de equidad y determinantes sociales, el análisis de las barreras de acceso y el contexto de programas prioritarios y el desempeño de los sistemas de salud, de formular y aplicar políticas de promoción y protección de salud a nivel nacional y subnacional, incorporando la gestión de riesgos en las políticas y promoviendo la integración de la salud en los planes y estrategias, de fortalecer los marcos legislativos y regulatorios y desarrollar mecanismos institucionales para hacerlos efectivos y garantizar el acceso universal y equitativo a todas las intervenciones de salud pública, incluidos los servicios de salud individuales y de base poblacional. La tercera línea que estamos proponiendo para los Estados miembros es fortalecer las capacidades de las redes integradas de los servicios de salud. La capacidad para mantener, por un lado, los servicios de salud rutinarios, incluidos los relacionados con programas prioritarios, y al mismo tiempo ampliar los servicios específicos en caso de una emergencia de salud pública, dependerá del nivel de adaptabilidad de la red y la capacidad de resolución de toda la red y sobre todo del primer nivel de atención. Es necesario aumentar la capacidad resolutiva entonces de las redes integradas de servicios de salud, pero acompañado con políticas específicas que rigen la disponibilidad, la distribución y la asignación de los recursos necesarios en cuanto a recursos humanos para la salud y medicamentos, entre otros. De tener la capacidad de responder con recursos humanos suficientes, con capacidades y habilidades, de fortalecer los sistemas de información de salud con la adopción de soluciones digitales interoperables para mejorar el acceso a los servicios de salud. No solamente integran datos específicos de enfermedades, pero también datos de capacidad de los centros de salud con el fin de mejorar la calidad. Y finalmente, adoptar las políticas de medicamentos y tecnologías para garantizar el acceso a los mismos. Un punto que fueron mencionados tanto por Francesca también para Zara es el tema del financiamiento. Es realmente importante que aumentamos y sostenemos el financiamiento público para la salud y la protección social. En el contexto de una perspectiva económica bastante precaria para la región de las Américas, será necesario un financiamiento público continuo, aumentado y sostenido en salud para apoyar la transformación del sistema de salud, para mejorar la resiliencia y apoyar la recuperación de los índices de salud y desarrollo. Los esfuerzos para avanzar hacia el objetivo de 6% del PIB asignado como gasto público en salud y eliminar el pago directo que se convierte en un obstáculo de acceso son más necesarios que nunca y que la región sigue lejos de alcanzar este objetivo. Es necesario aumentar las inversiones para desarrollar las capacidades de funciones esenciales y de nuevo priorizar las inversiones en el primer nivel de atención, asignando 30% del gasto público de salud al primer nivel de atención. Igualmente, para mejorar la capacidad de adaptabilidad, de respuesta y resiliencia de los sistemas de salud, es necesario aumentar también inversiones en infraestructura. Finalmente, una acción gubernamental específica para reducir el nivel de informalidad en las economías de las Américas, junto con el desarrollo de programas y mecanismos de protección social, que protegen a las poblaciones en situación de vulnerabilidad, acelerará la reducción de la pobreza y apoyará la recuperación. Todas estas acciones son críticas, no solamente para garantizar que las poblaciones permanezcan protegidas en caso de futuras emergencias de salud pública, pero también para avanzar hacia el acceso universal a la salud y cobertura universal de salud en las Américas. Muchas gracias.
Muchas gracias, James, por la presentación, y en este momento vamos a abrir para una sesión de preguntas, comentarios, y estoy aquí mirando en el chat. No veo muchas preguntas, pero voy a empezar con una que está dirigida a cualquiera de los panelistas. En realidad los tres podrían dar su perspectiva, porque creo que alcanza para eso. Y la pregunta la voy a leer en inglés porque está en inglés. As an editor of the International
Como
Journal,
editor del International Journal de Health Governance, me interesa
what kind of answers they would like to find in the research from our potential authors? What should be the topics and types of our future publications, case studies, conceptual papers, literature reviews, observational studies, etc., that could help policy and decision makers? And como para el balance de género, le voy a pasar primero a James, porque las colegas están en mayoría. James, te paso para una primera respuesta y seguimos luego con Zara y Francesca. Adelante, James.
That to respond to the question in English as it was posed in English. You know, when we were developing the work with the countries in the Americas around this strategy, you'll recall, Amalia, that one of the core issues that constantly came up in our discussions with them was the issue around leadership, stewardship, and governance. And when we were putting together the proposal jointly with the countries, we had discussions about whether it was important to create an individual or distinct line of action in terms of governance and stewardship. But in the end, I think what we heard from countries was that this issue is important across all the areas of work. It cuts across the transformation of the health system based on primary health care, on financing, on supply chains, on production of vaccines, technologies. The issue of governance, stewardship, and leadership is really key. And some of the data that we've seen coming out of the stock take in WHO Geneva on the 3 billions suggests an interesting fact, and it's this: the level of preparedness prior to the pandemic is not necessarily directly related to the capacity response. What we've actually seen is the most critical issue in terms of response to the pandemic has been the capacity of governments in terms of their leadership and stewardship of the overall response based on science. And so this is, I think, a critical area that we need to begin to look at. How we have these distinct mechanisms and, I suppose, various inputs that are necessary for the response, but then how these need to be driven to action through effective leadership and governance, and how we mobilize the scientific community around a situation whereby we can generate the best evidence and the policies necessary.
Thank you, James. Zara, ¿quieres comentar?
Yeah, no, thanks. I think it's a great question. I would say there's two areas that I think are going to be very important to do further work on and further research. One is that it's linked a bit to what James is saying, but the metrics that we have to actually assess preparedness capacity and capabilities, with the metrics that we've been using, we've seen haven't actually predicted how countries perform with a pandemic. So I think that's one key area. And I know also WHO and OECD and the bank, everybody's sort of looking at this. The second one is around sort of the investment prioritization. I think a lot of people are, we can think about what needs to be done, but I think we need to think how we prioritize. I think a lot of work, and at the bank, we're looking at that, thinking about the investment frameworks of, in countries that have a lot of they can have a lot of demand in the health sector, but it's not just the health sector. There's obviously other needs in the countries. We're going to have a fiscal the fiscal crisis, how do you prioritize investments and make them context specific? So I think that's going to be another area that's very important. Thank you.
Thank you, Zara. Francesca?
Sure, very much mirroring, very much completely agree on the issues of stewardship and leadership. And that made a huge difference to the speed of reactions and taking this whole of society approach, because moving forward, clearly we need to put issues of crisis and resilience of the health system as very much high on the agenda, the priorities of prime ministers and leaders, not really just of the health sector alone. But perhaps two other things. One is obviously the critical importance still of the health services research, which that can be through case studies, literature review, observation studies, as you mentioned. But we need to understand much more what were the critical elements that made the difference in countries beyond the leadership. And those were not just the things that were looked at in terms of pandemic, purely narrowly thought of pandemic preparedness. It's really that look more broadly at health system and interconnected systems that needs to be looked at. And yes, completely agreed, Zara, we do need to have better indicators and measurement of all those different elements that make a difference in the context of the pandemic. There's probably also the issues more for having more translational research. So really having a much more multi-directional integration between different type of research, whether it's the basic research, patient-centered research as well, population-based research. These elements and aspects are somehow not looked at as much and definitely deserve more attention moving forward.
Thank you, Francesca. I have a lot of questions and comments in the chat, and we are 1 minute from 10 o'clock. So I will ask the three panelists if it is possible to stay for 5 more minutes so that we can run few more questions before we close. Is that okay with you? Okay. Antes que nada, muchos comentarios felicitando las exposiciones, las presentaciones, todas muy bien recibidas. Tengo lo que voy a hacer ahora es que quizás combino algunas preguntas y hago las preguntas a cada uno de ustedes para ahorrar el tiempo. Tenemos una pregunta que va directamente a Zara, que la voy a leer en inglés. Thank you for your presentations. And Zara mentioned that the bank is focused on a green recovery. How are you involving the health sector in this agenda? Zara?
Sorry, Amalia, can you say that question again?
The bank is focused on a green recovery. How are you, the bank, involving the health sector in this agenda?
No, thanks very much. I mean, so part of all our projects, when we process them, climate change is a corporate priority for us. So we actually integrate it in every sort of health project that we do. So, for example, for our vaccine projects, we make sure that the cold chain equipment that we use are actually using sustainable have sustainable energy models. If there's facilities that are built, we make sure that they are sort of resilient to climatic change. We integrate training of sort of the impacts of climate change into healthcare worker trainings. So there's actually a really wide variety of activities that we are integrating directly into our health projects. Thank you.
Thank you, Zara. Bueno, esta pregunta, Francesca, I will do the next question and maybe you can answer and then I will place one for James. There has been a huge shift in trusting science and evidence. Are there regional variations? How do we regain the trust by the public and some policy makers and prevent the politicization of evidence and science? Francesca.
The easy question.
Interesting question.
Yeah, no, but there is a huge agenda of trust. Trust in governments, trust in science, which obviously has to do a lot with the way government communicates with society, but I think it goes way beyond just the communication. Do, for example, people trust that there is the people that that are making decisions also have the qualifications and the competences themselves. So is the communication done in a way that reflects also competence of governments in addressing issues such as a crisis and so forth. So this whole issues of competence become particularly important. The integrity element, because trust in the context of the crisis has to do with making sure that there is systems which are have a strong standards of integrity. So I think addressing that trust aspects requires really having again a broader look at how government functions in a way that we ensure that not just the communication is clear, is science-based, but also that you build that integrity and competence around the way government functions that build then the trust of populations. There's been clearly then a lot of confusions of communicating even basic science in a context in which science was evolving. So perhaps being also much clearer about what do we know already, what we recommend, or what is the policy and action which is made based on the best knowledge available, but knowing that some of the knowledge might evolve as obviously science research and knowledge builds up. I think even that way of communicating in a simple way, that there might be an evolution as well, that is really critically important. So these are just some elements, but it's a huge task, definitely a huge task for the future.
Thank you, Francesca. And the last one, because we are running out of time, it's not the last question, but I will apologize with everybody that we cannot really take more. But this maybe James, you could provide your input. The question is, if you think that it is imperative to promote digital health to make traceability more easy in prevention of future pandemics, and also to promote prevention in health in general. James. El micrófono, James. Gracias.
That's really a great question. And I think the short answer is yes. We are very much aware, as Francesca presented as well in terms of data in the OECD, but broadly also in the Americas, the massive growth of digital health technologies as a means to increase access and coverage in terms of healthcare. We have enormous opportunities. We've seen that during the pandemic. And just even recently, in terms of the structure and organization of health systems, how we sometimes when we think about digital technology, we think more of higher, more resource-intensive technologies, but how we bring that down into the communities, into the houses of people, so that they have access to the healthcare providers, and even through community health workers, how we mobilize digital health technology as part of the primary care strategy. One concern that we do have, and again, we are having this discussion with our countries next week, is the barriers to access digital technology. So there is a direct relationship here in terms of income quintiles, in terms of access to the internet. We estimate that over 200 million people in the Americas still don't have access to the internet. So what are the implications as we roll out strategies in digital health technology to address that? We do have to kind of break down and address those barriers as well.
Thanks, James. Bueno, con esto yo creo que tenemos desafortunadamente que cerrar la reunión, pero antes quizás me gustaría compartir con ustedes un comentario de una de las participantes que creo que capta bastante bien el sentido de lo que hay que hacer, como para también dar voz a los colegas.
Voice to our colleagues. The comment extends congratulations to all the panelists.
La que causó la pandemia COVID-19. Sin duda, solo la percepción de los altos mandos encargados de la gestión de políticas públicas para reprogramar con énfasis en el primer nivel de atención y en redes integradas, permitirán el acceso con equidad y calidad, no solamente para COVID, sino para todas las patologías desatendidas. Es una contribución de Judith Díaz Bazán, del Ministerio de Salud de Argentina. Gracias, Judith. Me gustaría leer más contribuciones, pero no tenemos tiempo. Bueno, y para cerrar, para quizás puntualizar algunos mensajes clave. Uno, hemos observado, lo cual es sumamente interesante, que tenemos 3 agencias, yo diría que 3 agencias de gran peso en términos de la dinámica y la salud global, la OPS, OMS, el Banco Mundial y la OECD, presentando sus perspectivas en relación a un tema que es un tema común, el tema de resiliencia. Y lo que sí está claro es que hay bastante, diríamos, una visión compartida, no solamente de los problemas, sino también de las soluciones. Yo creo que la verdad, destaco el tema de que las 3 agencias identifican la atención primaria de salud como un enfoque estratégico y además operativo en términos de fortalecimiento de sistemas y de servicios, como para fundamentar intervenciones que nos ayuden a fortalecer y construir sistemas de salud más resilientes, y que puedan responder, no solamente ayudar a esta transición y sacarnos de la pandemia, sino responder mejor a futuras pandemias. Entonces, eso es claro en las 3 exposiciones. Por supuesto que hay los detalles, pero es un elemento importante. Y quizás en este sentido, destacar que la atención primaria de salud como abordaje estratégico, por supuesto, establece una visión en salud, que es una visión con valores centrales de derecho a la salud como derecho, la equidad y la solidaridad, que por lo tanto, si tomamos ese marco de referencia, entonces eso orienta las inversiones, la transformación de los sistemas de salud e incluso las transformaciones en organización. El tercer elemento que me parece fue también presentado desde las 3 perspectivas es el hecho de que si bien hemos observado grandes brechas y grandes retos en la pandemia, también se han observado innovaciones. Es decir, la pandemia también forzó a los países a generar cambios en un corto tiempo y la verdad, innovaciones como por ejemplo en el modelo de atención, el uso de la tecnología de información, pero no solamente de la tecnología, sino cambios en modalidades de contratación, en cómo aumentaron la capacidad en recursos humanos, etcétera, en cómo aumentaron equipamiento. Entonces, también es un elemento común, por lo tanto, en construir resiliencia a futuro, estas innovaciones y la aplicación del aprendizaje va a ser sumamente importante. Y por último, el tema que también se reconoce como fundamental, la capacidad de rectoría, gobernanza, que tiene que ser fortalecida tanto a nivel de los países, pero también la gobernanza global, para poder de verdad impulsar los cambios que en algunos casos son cambios sustanciales en la manera en que se organizan y se gestionan los sistemas de salud, incluyendo los vínculos con otras áreas para poder tener un abordaje más integral de la salud de las poblaciones. Así que yo con eso me gustaría cerrar aquí el seminario. Muchísimas gracias, Francesca, Zara, James, por las excelentes presentaciones y a los participantes por acompañarnos en el día de hoy. Muchísimas gracias.